so many people think that hospice is about giving up, and it isn't. It's not giving up at all. There's a myth that the medication that we provide causes a patient to pass. And once families are educated on what happens to a body whenever it starts to naturally shut down, then if that's properly explained, then that's where they find that peace. Our goal at the end of the day is for them to pass peacefully and comfortably in their sleep.
What's up, guys? Welcome back to another episode of The Device Girls. Today we have on Lindsay Goodman. She is a hospice RN clinical director for Alpha Omega Hospice here in Abilene, Texas. So we're going to just deep dive into what hospice care looks like, what her role is like, and some of the challenges and some of the great things about hospice. So why don't you go ahead and introduce yourself?
We're so excited you're here.
I'm so excited to be here. So my name's Lindsay, and I am an RN. I am the clinical director of Alpha Omega Hospice. And so I've been doing hospice for about almost 7 years.
Okay.
Wow.
And, from when I was younger, my grandmother was on hospice, and then so was my grandfather.
Okay.
And so just being able to see the care that was provided to them towards end of life, and then the comfort that they experienced on top of not going to the hospital or back and forth to the doctors. I mean, they were able to stay home and be comfortable, and then again have quality of life. And so it's definitely a beautiful thing to experience. And so when I witnessed those things, I knew that I wanted to do nursing, but hospice, it was just kind of it was just pulling on my heartstrings. And I knew that that's what I wanted to do. So that's how I got into hospice.
So when you started as an RN, what did that look like? What side of the industry were you on? And then where and when did you transition?
Sure. So, I mean, I had done a few different things. So I was an LVN first, and I was in a doctor's office. I'd been in the hospital. I did do long-term care in an Alzheimer's unit for about 6 months. And that's what sparked, that's what re-sparked the hospice. They would have hospice nurses come in, and then we would just start chatting and whatnot. And so one day they said, hey, we have an opening, we're growing, and we would love for you to join the team. And so, with hospice, a lot of times they want you to have experience. And so I had not had any, hospice experience out in the field. And so, I told them, I was like, I don't have any experience, I mean, are they going to, hire me? And they're like, well, just come in for an interview. Like you're going to, do that. And so I was like, okay. And then they gave me a chance. And since then it's just been nonstop.
So you mentioned that you don't learn about hospice care as a nurse from a nursing perspective in nursing school.
No.
So what does that training look like, and kind of?
So a lot of it, I was very fortunate to have a clinical director and a program director that was willing to mentor me. They saw the passion that I had for it, and they were available to me for 24/7. And I tell my nurses now that whenever we hire them, it's kind of like, listen, I called my program director for 6 months, probably like 20 times a day, just because hospice is so, again, I mean, it's not taught. And it's such, and no patient is the same, right? So you could have a patient with the same disease processes, but yet they're going to be different. And so just trying to keep that open mind and being teachable is very important. Thing. Yeah, absolutely.
So what does the day-to-day for a hospice nurse kind of look like? Because I feel like a lot of people don't have a good, like, unless you're experiencing hospice with somebody, they don't have a good idea of what that really looks like.
For a hospice nurse,
Mhm.
sure.
Yeah.
So we have our RN case managers.
Okay.
And so what they do is they go out and do what we call routine visits.
Okay.
Hospice is covered 100% by Medicare.
Oh, wow.
Everybody has a hospice benefit that they can elect. And so, and a lot of people don't know that.
I did not know that.
But it's paid for 100%.
Wow.
That's included in their medications, like their comfort medications.
Okay.
That's included with their medications that are related to their terminal diagnosis for what they're on hospice for.
Okay.
And then we also provide toiletries and things like that for what they need.
Wow.
So our nurses will go in and they'll do routine visits, and then we do what we call PRN visits. So those are visits that are as needed. So if we have a patient in a crisis or somebody's not feeling well, then we can also make home visits and go see those patients. So they have their own caseload, and so they have the same patients that they see.
Wow.
And then of course they also, we do admissions, and so it just kind of depends from that aspect. And then per Medicare guidelines, we have to do recertification visits.
Okay.
And so the first two research are 90 days. And then after that, it's a 60-day. And what that means is that we chart the decline, and basically after the first two, our nurse practitioner will go in and she'll see and do face-to-faces and, say, is this patient still appropriate for hospice?
Right.
And so that's really kind of what they do. It's
Okay.
they work Monday through Friday, but we also take call. So it can be very, very busy and
Wow.
very heavy.
Yeah.
Sometimes.
Can
I
you
bet.
walk us through the process of if a patient is at the place where this is something that they're needing to step into
Sure.
and wanting to step into? What does that transition of care look like from hospital to home? What kind of equipment, technology, what have you, do you bring in to support and kind of, I guess, breaking the stigma around what hospice is a little bit?
Yeah.
Are they bed bound? Are they up and driving? Are they,
For sure. So again, everybody is different. And so, depending on what their terminal diagnosis may be, again, like if it's COPD or if they have some sort of cancer or if it's heart failure, Alzheimer's, dementia. And it's not necessarily everybody doesn't have to be a transition from hospital to home.
Okay.
Or hospital to a long-term care facility or
Okay.
an assisted living.
Mhm.
Again, people, if they're educated and they understand when they can elect that benefit, then again, they can be at home and they can just be like, we don't want to go to the doctor anymore. Like we just want to have quality of life. And stay at home and enjoy life. Because, whenever I'm explaining and giving education to families that about hospice, it's like, our goal at the end of the day, number one, yes, we're a patient advocate. And then number two is quality over quantity. But a lot of times when you can get a patient who comes on hospice sooner rather than later, quality will equal quantity. Like you can
Right.
get quantity because you feel better.
Right.
You're de-prescribing these medications that they may not necessarily need to be on, or they're making them feel bad.
Right.
And so once we get their symptoms managed, whether it's shortness of breath, pain, anxiety, all of those things, then they start to have quality of life.
Right.
And so it's such a beautiful thing because so many times we will admit patients and their families, they're like, I think they're doing better since they got on hospice. And
That's amazing.
and I said, it doesn't surprise me. And let me explain to you why. They're having quality. They're able to do what they want. But again, not all of them are bed bound. Not all of them, use assistive devices to ambulate. Some of them are, again, they still drive or they go to church. Because again, if somebody has a cancer diagnosis and they choose to no longer seek treatment, I mean, we don't, more than likely, I mean, it's maybe a 6 months or less diagnosis because technically that's what hospice is.
Right.
But at the end of the day, nobody knows. Only God knows.
Yeah.
Have you, you said something earlier too, and it made me think about this. Have you ever had a patient, I'm sure you have, come out of hospice?
Yeah.
Wow.
Do you have a specific story that
there's one
comes to mind?
And I'll tell you, he gets me so excited. There's one, he was on service and he was not really, of course, was not feeling well, just really not coming out of his room, and real weak, all the things. And so we kind of, we got him on hospice, looked at his medications, kind of, saw what basically would get him comfortable as far as, if he was hurting or if he had anxiety or all the things. And it was time for his research. And it was he was getting stronger and getting better just because he wasn't on everything that he was on previously, but yet his symptoms were managed. And so we had a sales meeting. And one of our liaisons, she said, he's oh, he's up there doing great and he's running the bingo hall now up there. And so it's I mean, but we're still
That's
able
awesome.
to follow the patient, right? Because he still has that terminal diagnosis. It's just he found a new will to live almost,
Wow.
I mean, it's just
That's
because he felt
amazing.
better.
Yeah.
So, I mean, and I think, too, there's such a black cloud over hospice just because people have had either bad experiences or they've heard of horror stories, or maybe it was hospice a long time ago, and just like anything in the medical field, hospice is ever evolving, right? So what hospice was 10 or 15 years ago, that's not what hospice is today.
Right. Completely different.
And so just trying to get that out there of letting people know what your right is, what your choices are, and everything that the hospice team, because we have an amazing team. We make up of, we have our RNs, we have our aides. Our aides go 5 days a week to see these patients. We have a social worker, we have a chaplain, and then of course my boss, which is our program director, and she's done a fantastic job.
That's amazing.
And so I was sitting there talking to her the other day, and I said, I love waking up and coming to work because I enjoy it.
Yeah.
I mean, it's like you're where you're supposed to be. So, but I'm extremely passionate about hospice and what we have to offer. Just because, again, you have you have success stories of a patient coming off service, but then you also have the success stories of our patients who actually pass peacefully and comfortably, and they're not hurting.
Yeah.
So.
Wow.
So primarily, because you mentioned Medicaid coverage, but what does that look like for a younger patient? And
Yeah. So again, Medicare is covered 100%, and then we do take Medicaid.
Okay.
But then we also take charity cases.
Okay.
So for somebody who doesn't qualify for, for those types of insurances, then we do charity and take those patients on.
That's amazing.
Absolutely.
That's awesome.
Wow.
What about just a patient's regular insurance? Say it was me and I have insurance.
So that would more or less, again, it would kind of be
depend on the plan.
Yeah, kind of like the plan. Sometimes they have a copay, I guess, but a lot of times like that, we would just do a charity. So you're not having to pay the copay or whatnot.
Oh, that's amazing.
And then that way we would come in and take care of the
So there's a lot of happy sides as well to hospice, just because of the peace aspect and them being able to stay in their own environment. What are some of the hardships that you have to face in the industry?
I think a lot of it can be family dynamics.
Okay.
Another one is they're just not educated,
Mhm.
and so they don't understand. There's a myth that the medication that we provide causes a patient to pass. And once families are educated on what happens to a body whenever it starts to naturally shut down, then if that's properly explained, then that's where they find that piece of, wait a minute, like they really need this medication, because towards end of life, patients have what we call terminal pain and terminal anxiety. So that's different from the pain and the anxiety that you and I have, right? Because in hospice, we focus more on because we're human, we're tangible, like to see, feel, touch, like we like sure things, right? But in hospice, so we're trained to focus on what's going on inside the body. And so once things start to naturally shut down, things happen on the outside of the body. But it's not an always where we see those signs, but we're trained to monitor vital signs. Patients can have what they call ear pinning. They have what they call modeling, like all the different signs. Not everybody has them, but again, we're trained to assess their vital signs as well, and then of course their breathing and those things. So once again, families, caregivers are properly educated, and the care team sits down and spends time with them to go over, hey, this is what could happen. And if it does, this is what we're going to do. But at the end of the day, you're not alone.
Right.
Because we have RNs on call 24 hours a day, 7 days a week. So just knowing and giving them that peace and comfort to know that you have someone there that's willing to hold your hand, then I think, again, that makes all the difference. But the key is the team, right? It's the team.
Absolutely.
Because you can have a good hospice nurse and you can have a great hospice nurse.
Right.
And so you want somebody that's going to be compassionate, somebody that's going to take time to listen and be resilient, that's going to stay up to date with their education and their training. So those just nurses that are hungry. And that's what I love about our team is, we have such an amazing open line of communication. And again, our program director, she's all about communication and letting everybody on the team being in the loop and not just
with every patient.
That's
amazing.
And so that's taught us to be able to do that. And in doing that, we gain trust with each other.
Absolutely.
So on that same note, since you're discussing the families, how do you provide peace to these patients too? Because I can imagine some of them probably come in scared and
sure.
They know that they're going to pass at some point soon.
Yeah.
So.
I think that number one, listening.
Yeah.
To what they have to say, because a lot of times the families and even the caregivers, the patients, they start grieving way before a patient passes,
right?
Just because they've been given a terminal diagnosis, and so I think that's where it comes in as far as like I said, listening and just providing them the education and meeting them where they're at,
right? Okay.
And so I think they just want to be heard a lot of times too. And it's one of those things that, even if we've seen it, it's not like, we don't say, hey, I understand how you feel, because we never do.
Right.
And one thing that's always in the forefront of our mind is, number one, of course, is compassion. And then being humbling and being humbled, and just knowing that these families, these patients are going through possibly the worst time in their life for what they think, right? As far, they only get to lose one mother, they only get to lose one father. And so when you get to that point, it's just, again, it's just all about just being there for them.
Right.
And I think too that one of the things that we run into, or that we see a lot, and it's it's very common, just whenever a patient starts to get closer, the family wants them. They're like, I just want them to be able to be at rest. I just want them to be comfortable and not have to live this way. But there's nothing like that last breath, and then reality hits. And so I think that being there and just educating them and saying, hey, like, take all of this in, talk to them, tell them how much you love them, even though they can't answer you, because hearing is the last thing to go. And so it's one of those things, let them know it's okay to go. Let them know that you're okay and you're going to be taken care of. And they want that reassurance, that the patients do. And you'd be surprised, the things that you say and tell them, and people that come in, and then they can let go. So it's a beautiful thing.
Wow.
It's so humbling to be a part of.
Yeah.
Do you guys provide anything for like the families and everything after, like right when that patient passes? What does that kind of look like in that process?
So we have our chaplain, and then our chaplain can provide care throughout their stay. But then we also provide bereavement for a year after the patient passes.
Wow.
And then, of course, we've also had patients, families that have called and said, hey, I'm not sure where to go. I need counseling. I'm grieving. I don't know what to do with this. And then we can give them the tools that they need to talk to somebody about it.
Awesome.
So, yeah, so much.
How does that role look like for the nurse in that moment of like really, I guess, reading the room and like knowing the boundaries of like, where do I step in and like, whether it's pray over this patient and this family, or like, rub your back, or speak up and try to just encourage like the peace in that moment, or just take a step back and let the family.
No, I think that's one of the superpowers of hospice nurses, is the discernment to be able to read the room. And I can't even explain it. It's such a special feeling, because no matter what, there's cultural differences, right? There's age differences, and so reading it, it's so important to be able, because again, this time is so fragile that you don't want to overstep any boundaries. But I can truly say that that one of the things for being a hospice nurse is just, having the discernment to know when to step in. And then too, I mean, you have people that they may not have a higher power, or they may not believe, of things that going. I think one of the most beautiful things that I've been able to witness is somebody ask for Jesus to come in their heart right before they passed. And so it's just kind of one of those things, right? That, I mean, it's just, you just take a step back, and you're just kind of like, wow. So, but I mean, I think that everybody, and people who may not, be on that side of things, we can go in and do a head to toe assessment, and I mean, we can pray over that patient, and they don't even know, and just offer them peace and comfort, and just bless them, because at the end, that's our goal, is that we just want our patients to be comfortable throughout the whole process.
Right.
So with your team, since you're so like team oriented, everybody's so up to par and on each case and each different patient, do you really rotate through stuff, like where you each get touches with the patient,
Mhm.
or is it more of a one-on-one, like this is my set nurse and I love this nurse and I only want this
Yes.
nurse,
Mhm.
or
Yes.
what does that look like?
So, I mean, and that's very important. So basically, our aides, they have a set schedule for certain patients,
Okay.
and they see those patients 5 days a week,
Okay.
and they see them. It's the same patients that they see. Same with the nurses.
Mhm.
We have them to where they're kind of, we have a nurse in Haskell and Stanford, Sweetwater, and then we have one out in Tuscola and Ovalo.
Okay.
So we kind of have them to where we're not having, 2 or 3 different nurses going to the same facility and it's 30 miles away.
Okay.
Right.
But we do cover a 60-mile radius from our
Okay.
office in Abilene. And so, again, Rotan,
Mhm.
Haskell, at Baird, I mean, Clyde, we go out that way. And so it's very important, especially that I've seen that a patient has the same caregiver.
Mhm.
And especially, again, with different disease processes, because a patient who has Alzheimer's dementia,
Mhm.
you keep introducing new people,
It
Right.
is. Yeah,
then
it
that
is.
can cause a
Mhm.
little bit of,
disruption.
Mhm.
correct, yeah. But whenever the same aide goes in and, knows what to do and knows how to care for them and talk to them, then, I mean, that provides comfort. And even with our aides going in 5 days a week, I mean, that's improving quality of life,
Yes.
right? Because these
Yeah.
patients are getting taken care of and they're getting to see people.
They're getting some
Yeah, of
social
course.
interaction.
Absolutely.
Yeah,
Yeah.
for sure.
Yeah, for sure.
Yeah.
So it's so good to watch.
Yeah.
So when you transitioned into hospice, I'm
Mhm.
sure
Yeah.
there were some difficult
Mm-hmm.
times for you. Can you maybe touch on that,
Sure.
or a
Yeah.
specific patient that was most difficult?
So I think for me, when I was first transitioning into being hospice, was setting boundaries.
Mhm.
And it's so easy because you do have your own caseload of
Mm.
patients, and you work 8 to 4:30. But then your families have your phone number,
Mhm.
and they communicate because if they
Mhm.
need something, and we educate them and let them know, hey, this is when they work. But you build that rapport,
Yeah.
Mm.
and they start to trust you, and so they want to reach out to you all the time,
Right.
And so, I mean, we completely understand that, but I think like whenever I first started, it was something that I just wanted to be like I know these are my patients, and so
Mhm.
if they need me whenever, like I'm going to be here.
Yeah.
But boundaries are just so important because on the flip side of that, self-care is so
Yes.
important
Yeah.
for us to be able to decompress.
Right.
And so we really, just educate and just support our nurses and say, hey, like, it's okay. Like, I know you're going to be off, but we can take care of your patient, and just
Right.
giving the nurse that, because they really take ownership of each patient that they
Mhm.
have,
Yeah.
and each family member.
Mhm.
So, but I think boundaries would be that's
hardest thing.
the most difficult.
Yeah.
So.
For sure.
So what did you do to help really learn to set those? Like, what was it?
It took practice
Okay.
of saying no, right? I mean, it took, but it took me saying, like, I'm not on call when I
Yeah.
get off. So if you need something, you can call our on-call number,
Okay.
and just letting them know,
Mhm.
right? And making sure that they know, hey, the nurse that is on call is going to take just as good of care as you as I will,
Mhm.
even though they may not believe that,
Yeah.
right?
Yeah.
Right.
I mean, it's still one of those things because they will.
Yeah.
But it's just a matter of that patient just kind of letting go
Mhm.
and just trusting kind of
Yeah.
the process. So,
Yeah.
but
Wow.
Yeah.
I had a question and I can't remember.
I love how
but-
much passion she has for
I
this. It's
know.
awesome.
And your demeanor and just you're so soft spoken, and it's so comforting that like I mean it's so peaceful. I mean, if I was a hospice patient, that would be like the most comforting thing to me.
Absolutely. Well,
That's
thank you.
amazing.
That's,
Yes.
thank you.
Okay.
But yeah, no, I mean, I am. I'm extremely passionate about it because there's so much that we have to offer.
Mm-hmm.
And I think that's the most important part of all of this. Like, patients don't know what we do behind the scenes. So, we have what we call IDG, and we have our medical director, all of our nurses, our chaplain, our social worker. We all come into a meeting and we go over the patients and their care plans. We talk about ways that, hey, this patient is still struggling with this. This is what we've done. How can we, how can we get them to where they're feeling better in a holistic standpoint? Because it's not just a physical, right? It's more of, it's a holistic. So we have to look at the whole body, and that's where the chaplain and the social worker come in. We also have volunteers. So they can come in and sit with patients, and it's wonderful too, because I mean, we have some patients that don't have anybody.
Yeah.
And I mean,
how often is that?
I mean, more than
you would think.
Yeah. And too, right? I mean, there's different circumstances and family dynamics with every patient. But again, I think that's where we can come in and we can sit with them, and our volunteer, and then we have our chaplain and social worker. And I mean, like, all the things that we can go in and just, be there for them, hold their hand at their, last seconds or minutes or hours, because we just never know. And that's another thing. It's like, our nurses have their caseload, but if a crisis or an emergency comes up, I mean, we want them to stay with that patient and do whatever they need to get the patient comfortable. Myself, and then our program director, Misty, and I always say this whenever I'm interviewing for new staff, that we've been in the field. Like, we've been case managers, so we understand to an extent, like, what it's like to deal with those things. And so we'll go out there and see patients if, we don't want our nurses to be just so overwhelmed with whatever may be going on that week, whether we have a lot of admissions, a lot of patients pass. And then if they need to go over here and do this visit, then, myself or Misty, I mean, we'll just go out and we'll see patients ourselves. I mean, and that's the teamwork that I absolutely love and adore about this team. Because you don't get that everywhere. No, you just don't. You don't. You don't get the autonomy that we offer for caring for a patient. But then we also have, our medical director, myself, Misty, everybody is available if something is needed. So it's there's so much, again, behind the scenes. But it's such a beautiful thing to be able to watch everything happen.
What does that look like for a family who's trying to evaluate hospice programs and who to pick and how to kind of make that decision to bring them into their home, and into their life? So, they have, every patient has a choice. They have, they can choose whatever hospice that they would like. And a lot of them, they don't know that. They don't know that they actually have a choice, or that they can, or even that there's other hospices out there. But that's where I think the first part of the education comes in, is asking, what is this? Because again, a lot of people
think hospice is they're going to, we're going to put our loved one on and, they're going to be gone in a couple of weeks or months.
Mhm.
And that's not always the case.
Mhm.
Mhm.
And, like I said, it's the sooner a patient can get on hospice, the sooner their symptoms can get managed.
Mhm.
And a lot of times with that quality comes quantity.
Mhm.
And so, you've got patients on service for a year or 2 years.
Mhm.
And people say, well, how is that possible? Well, it's possible because there's a decline. They're having a decline, a physical decline,
Mhm.
that is going to continue to qualify them to keep them on service. They're utilizing the medications that we offer.
Mhm.
They have increased shortness of breath, or they're sleeping more, they're
Mhm.
decreased appetite, those things, or they're having a lot of falls,
Mhm.
infections. And so that's it, you just never know.
Yeah.
But so I think the first thing is that, okay, you need to talk to your loved one. And it's so important to have the conversation early and find out, like, what are your wishes?
Right.
What do you want? If this happens to you, do you want to be on a ventilator? Do you want to be intubated? Do you want chest compressions? Do you, or these are hard conversations that
Mhm.
are absolutely necessary, because again, nobody knows, right, when something's going to happen.
Mhm.
And so if you've already had those conversations and you're like, okay, well, I know that they want to be a DNR, so they don't want to be resuscitated.
Mhm.
Yeah. And then, so if you know that, and okay, they don't want to be in the hospital when they pass, they
Mhm.
don't want to be on machines. So it's like, okay, we know that. So, and then again, a lot of times too, a patient, they want to be at home.
Mhm.
And you had asked earlier about like equipment and so forth.
Mhm.
So we do provide, it's what we call DME.
Okay.
So we provide hospital beds, oxygen concentrators,
Hmm.
bedside tables, pretty much anything that you can think of
Mhm.
that a patient would need to be able to live comfortably at home and
Oh.
still have that quality of life. Shower chairs, all the
Okay.
things. We provide those.
Wow. Okay.
Yeah.
So,
Love
and
that.
what would you say, like, what does the hospital do in regards to connecting patients with this service and different
Mhm.
programs? What does that look like?
I don't know how to answer this. It's gonna have to
I'm
be.
sorry, I even asked that
No,
question.
you're fine. But
What do you guys do though to help maybe educate the community
Advocate,
and
yeah.
patients that there's other options out there?
right, and that's where we we get out into the community.
Yeah.
We do the Alzheimer's walk. We do other things that
Yeah.
we have events at facilities. Our liaisons are really good about going out and doing activities. And then, for Nurses Week and CNA Week, they'll go out and provide goodies or lunch or
Oh,
breakfast or something.
Yeah.
So then
Good.
that way we can kind of get it out there that, hey, like, this is who we are and this is
Mhm.
what we offer. So, it's more or less just getting out into the community.
That's
What
amazing.
should we do?
Yeah. Well, we would,
Can't
I
believe
know,
that.
like, we would, if you guys do any sort of event or anything,
Yes,
we'd love to come volunteer or help with anything.
absolutely.
Your next, just that's something
For
we
sure.
like. We love to do outreach and
Yes, that
and
would be
be involved.
amazing.
especially in this community. I mean, I know Haley's from Dallas, but
Yeah.
I feel like I'm a part
she's-
of Abilene
I
at
know,
this point.
she is, and I just have such a heart for this community as well. And so,
Yeah,
anything that we can do to come help.
That
as
would
well.
be amazing. And two, if anybody wants to volunteer,
Mhm.
they just, go online and they can apply, and our volunteer coordinator will reach out to them. And volunteering looks different for
Mhm.
everybody. It's if you want to volunteer office time and go do activities or some things that we take out into the community. So if we have like baskets and stuff,
Mhm.
they can maybe put those together. They can do filings, things like
Mhm.
that in the office. And then, of course, we have volunteers that go sit at the bedside with with
Yeah.
patients.
Mhm.
And then I know we have some patients that love to play dominoes, and so
No.
we have
love
volunteers. Our
dominoes.
social worker, they go out and and then our social worker, she's really good. She makes homemade fudge, and so she'll take it to the
Oh.
patients and their families.
That's
And
awesome.
it's just not only are we at work a family, but our patients and their families become family.
Mhm.
And the most humbling thing I think about being in hospice and being a provider is you have these family members who are they're in such a delicate part, sensitive, it's so frail part of their life, and then we walk in just doing what we love,
Mhm.
but yet they
Mhm.
see us and they just think that we've hung the moon, or it's like we're their saving grace.
Yeah.
Mhm.
Do you know? And more times than not, the families, they say, we don't know what we would have done without you,
Oh.
or thank you for being a blessing, thank you for this and the care that you provided. And it's so funny because every single one of us that worked there, when we talk about that, and we just like, I get goosebumps talking about it, because I'm like, our families are telling us that, but in reality, we're the ones saying to ourselves, wait a minute, you blessed us.
Mhm.
Like, we didn't do anything.
Yeah.
Right.
We just went in there and educated you, because this is what we see every day. And that's what we did. But yet we're like, you've blessed us, you've welcomed us into your home, into your loved one's life. And it's just amazing to be able to be at that part of their life. And I always tell people that my passion comes from, I truly believe and feel that the end of life is just as important as the beginning.
Agreed. Yeah.
And it's not something that's taught.
Mhm.
It's something that comes natural and is learned. And I've seen people that hospice isn't for them. They get into the field and they think, okay, I really want to try this and do it. But they get into it and they say, you know what, this really isn't for me.
Mhm.
And I praise them. I'm like,
Yeah.
that, and I'm like, that's
For
perfectly
recognizing.
fine. Like, if it isn't for you, thank you so much for telling us that it isn't. Because if it's not for you, then we want to help you find what is.
Right.
Absolutely.
Yeah. So again, I mean, it just kind of takes a certain kind of person, to be in any field of nursing.
Absolutely.
Do you feel like there's kind of a major stigma around hospice of like sadness, especially like the people that work within it? And how do you think that we could maybe start to transform that and think of it more of a, not a happy thing, but a more positive?
Right.
And how do we get people to have a more positive outlook on hospice?
And even I think on death and dying, I think there's such a stigma on that people, they're afraid, or don't know what to expect, and it's not. I think with hospice, there being able to provide the education that families need, and like I said, it's different with every single patient.
Right.
And no passing, no death looks the same. And so that's where it's keeping an open mind of, going in there and earning these patients and their families, earning their trust to say, it's inevitable.
Right.
We're all going the same way.
Right.
And it's us wanting to be able to build that trust and the relationship of, we're going to walk you through it and we're going to help you. And I truly feel like that's one thing that hospice does that not being on hospice, it's just, there's that difference. And again, too, I think that people can get kind of like a bad taste in their mouth because they've had a bad experience, or they know
For sure.
someone that has.
Yeah.
And it doesn't have to be that way.
Right.
That goes back to what's the difference in a good hospice nurse and a great hospice nurse. And so that's what I'm.
So when it comes to like dealing and coping as a nurse in this industry, what does that look like? I mean, because it's hard.
Yeah.
I mean, every day, like that's heavy.
Yeah, it is.
And the attachment to your patients
Yeah.
and just like the care. I mean, even though it is such a beautiful and peaceful thing, like how do you, your team, how do you guys
Sure.
foster an environment of like healing and like moving forward and self-help?
Right. So compassion fatigue is real. Burnout is real. And so, I mean, we encourage everybody, take time off. Let's talk about it. Our chaplain is really good about telling all of us. We have a morning call every morning at 8:30 that, all the team is on. And so our chaplain is always, if you need somebody to listen or pray with you or talk, I mean, he's always available. Counseling is another one. And then also just kind of talking amongst your peers, your teammates. So I think that that's really important to be open and honest. Again, the self-care as far as, doing things that you enjoy, hobbies that you love, spending time with family, journaling, meditation, whatever those things are that are fulfilling to you, that are going to fill your cup, because we're always giving and giving and giving, and it's so easy for our cup to become dry. And we know that, okay, well, we have to fill that back up. So I think too, appreciation to our staff, and then team building, and kind of staying together. But too, it's when we have a patient that comes on, more times than not, let's say, we know the outcome, and that doesn't make it any easier,
right?
And we're still going to love and care for our patients and families just as we would any other patient. But also seeing the transition that a patient goes through, and then as far as keeping them comfortable. And the medications with whether it's anxiety, nausea, vomiting. I mean, anything that's going to help keep them comfortable. I think that we see them, say when we admit them, and then once they start to decline, and it's just we find peace in knowing that they're not going to be that way. They're not going to be uncomfortable. They're going to be dancing on the streets of gold, and they're not going to be, they're going to have quality of life. I mean, they're not going to be hurting anymore from this world. And so that's where our mentality is set. Despite, our nurses, they'll come in and they're like, this is a hard one. This is a hard one for me. And so, we just listen and we talk it out. So that's very important, to be open and honest, right? And say, this is a hard one for me. And not to keep it in, because that doesn't do anybody any good. And so, we want to do a team check almost, and say, hey, okay, how's everybody doing? This patient was doing this and they've been on for this long. And so, what's going on? And so that's kind of what we try
on the
to do.
flip side of that as well, how does that care look like for the families after the passing, and like not necessarily severing that tie, but like helping them with their adjust to their new normal and navigate grief? What does that look like?
So, kind of like I was saying, we do offer bereavement for a year after, but I still have families that I'm in contact with, and I haven't done bedside nursing. I haven't had a caseload in, almost a year and a half. So, but I still keep in contact with some of those families, because
they're your family.
They're my family. And I believe, sincerely, truly believe that we have built like just a special kind of relationship that, and I want them to know that they can still reach out to me. And if they are having a rough day or anything like that, that we can kind of talk it out.
Yeah.
And I mean, and we've done that before.
Yeah.
And it's so nice for the both of us, you know, not just them, but it's nice to
therapy.
be able, it's nice to
Mhm.
be able to talk about, you know, what this patient was like before they got sick,
Mhm.
you know, because we come in and all we know is the patient who's sick.
Yeah.
And we have to remember that their family has known them for years.
Yeah.
Right.
And they knew them when they weren't sick.
Right.
Yeah.
And so we have to be extremely sensitive around
Yeah.
those things because,
Mhm.
you know, wait a minute, they've known them for their whole life,
Mhm.
you know, if it's their parent or, you know, whatever. And then here we are just coming in whenever they're sick. So it's a matter of, again, reading the room, right? And knowing, okay, well, you know, and realizing this is what we have in front of us, whether it's a parent, a child, you know, that is the family member. I mean, you know, it's, you just, everybody's different.
Yeah.
Right. What I guess what's the youngest patient you've seen come through hospice? Or how is
So-
there a cap on that, or
You know, so the youngest that patient that I had cared for, she was 28.
Okay.
Wow.
And she had 3 kids. So that was the youngest that I had cared for. So we don't necessarily wouldn't do like pediatric
Okay.
right?
hospice or anything like that. Those typically would maybe go to the hospital or, you know, to where it's more like 24-hour around the clock care.
Okay.
But, you know, we've 20s, 30s, 40s. I mean, you know, you
Wow.
just never know. But then there are those that are my parents' age, you know, and you think, you know, my goodness, you know, it's just, you just never know.
Yeah.
And so it's just being humble and I think open to whatever their needs are at that age. Because of course, if they're 28, you've got somebody who's got 28 and who has 3 kids and a single mom who's living with her parents. And the kids, I think, were anywhere from 5 to
Wow.
9 or 10.
Oh,
So
gosh.
that it was an extremely hard case, you know. And then you have patients that are in their 40s who are diagnosed with, you know, cancer and they're married, and so you have, you know, a spouse that's fixing to lose in their 40s that it's fixing to lose their loved one, and then that they have family, you know, and it's just it's different for everybody. So, but it's never easy.
No.
It doesn't matter what it is. It's just, and I feel like the way that we can go in there is knowing that we're going to provide peace and comfort.
Yeah.
You know, so that's what gives us the peace to know. We know that we know the outcome, and our goal at the end of the day is for them to pass peacefully and comfortably in their sleep. So, you know,
That's
like I said,
great.
everybody's different. Everybody's different.
Wow.
And each case is different.
Yeah.
It's actually so interesting to talk about because Sarah and I had this discussion one day, I think it was a couple months ago, how we both, like, not that we're not compassionate towards like death or people that are grieving or whatnot, but we were just speaking about how we both haven't really lost somebody super close to us in that way. So it's harder for us to like sympathize but you're kind of giving me like a bit of a new perspective. So what's some like advice I guess you could give, because it's hard when you can't relate in a sense,
Right.
I guess.
Right. And I think that so much, if you have family members, like I said, that, say they've got, Alzheimer's or COPD or heart failure, end stage renal disease, cancer, something that they are just adamant and they don't want to seek any more aggressive treatment for. And say you see those signs, say you have a grandparent and they're like, I don't want to go to the hospital anymore. I don't want to seek aggressive treatment. I don't want to go to my primary care anymore. I just want to stay at home. And a lot of times they want to do that, right? Because it's just, but too, they get so tired and fatigued and weak, like just from that little trip. And then if you think about, patients who have Alzheimer's, taking them back and forth to the hospital, that's going to cause them to be more confused, and it kind of exacerbates their confusion and everything that they have. So if you start to see those things, you can always, ask for an evaluation at a hospice, and then a hospice nurse can come evaluate your loved one and just kind of see, okay, do they meet criteria? And if they do, like, this is the steps that we can take. And if they don't, these are some signs to look for whenever they do. But a lot of times too, I mean, people will have, they'll start increased falls, they're sleeping more, they're just withdrawing from others. They're not really wanting to go out and do anything or go play bingo or, go out and do activities. Whereas once they were, before they were. And so there's all kinds of things that you can look out for people who just start to decline, because at the end of the day, it's our body that's tired. Even if somebody has their mind, their mind is still there. It's just their body is tired, and our body and our heart just eventually will just stop. And that is the natural process of life. And, again, once we can get in there and just love on our patients. And when I go in and educate families too, I'm like, thank you so much for letting us love on your loved one. I mean, that's all we want to do is just love on them.
Where do you feel like when you, like, the line is, where do you feel like the line is for a patient finally making that decision, or that level of encouragement of, it is okay if you're ready for this. It's okay to not quit.
Right.
It's okay for you to say, like, I'm done with this. Where do you feel like you see that? I think, not like a giving up, but like,
and
just finding you just know that you're tired and you're done.
Right. And I'm really glad too that you use that terminology, because so many people think that hospice is about giving up, and it isn't. It's not giving up at all. Okay. So if a patient comes and they're on hospice and say they get an infection or they have a fall and they need antibiotics or they need x-rays or something like that, it's a case-by-case basis.
Yeah.
And so just because, say, you get an infection and you need treatment for it, we're going to treat that.
Yeah.
Right.
You get a cough or a cold, we're going to treat that.
It doesn't mean like we're done.
No,
you don't get to ever try to feel better.
No, no. And so, when patients come on also, some of the family, they don't want us to de-prescribe any of the medications that the patient is on, and that's okay. So, sometimes that, if a patient is taking a blood pressure medicine, that's keeping their blood pressure regulated, and maybe they're taking something to regulate their heart rate. So that's comfort, because, those are comfort measures. So if the patient were to stop that and say they go into a rhythm of AFib and they're uncomfortable, we don't want that.
Yeah.
We want them to be comfortable. So if they need that medication, then they can stay on that medication. And so I think, again, I mean, that people think I've got to stop taking all my medicine. I have to stop doing the things that I love, and another thing, it's I always tell families, and we always tell families that, okay, so your loved one is, say that the patient is able to sign their own consents for service. And so we stress to them, what you're doing today, we want you to do tomorrow while you're on hospice. We don't want you to think that you're signing consents and that we're going to prescribe you all of these comfort medications and it's not going to allow you to get out of bed, because that is the exact opposite. If they don't need those medications, they don't take those medications.
Right.
And so if they're able to go out and do certain things with family or go to church or go to the store, go do that.
Yeah.
Just because you're on hospice, that doesn't mean that you're bedbound now.
Yeah.
Or that you're housebound.
Yeah.
And so many people think that has to get to that point, and it doesn't. Okay. It doesn't. So it like you said, I mean, they just get to a point where I'm tired. These doctor's visits, these ER visits, they're wearing me out. And so that's where we come in and we step in, and our case managers do their assessment. They're in contact with, the medical director. And then we go from there to treat the patient.
What does that scope of medical practice look like in the sense of medication, prescribing medications, and what you can or can't give, or can you give everything?
So what we do is, so typically when patients come on service, we do what we kind of call a comfort kit.
Okay.
And we explain, and of course that's kind of like Phenergan for nausea, or it's morphine, or Ativan, or if they can't take those medications, it would be a different medication. And then we have like Levocin for increased secretions.
Okay.
Some patients, experience that whenever they get closer to passing. And so we provide those medications that will help those symptoms.
Okay.
And what we do is we get with the medical director and go over their allergies.
Okay.
And if they have an allergy to one thing, then of course, then the doctor will order something else. And so we get all of our orders from our medical director. And but the autonomy also comes with, and that's where training for being, specifically a hospice case manager, and going in and doing a head to toe assessment, so that if there is something abnormal that's going on with the patient, when we talk to the medical director, we can give them a precise assessment and say, this is what we're seeing. And then a lot of times too, we can say, we suggest, what do you think?
Yeah.
And they either say, well, you know what, let's try this route first. Or they can say, okay, well, let's do this at this dose and this many times a day. But that, again, it's just kind of like, it's so much autonomy. Whereas if we see something that's not normal, or that's not the patient's baseline, then that's when, we do our assessments and then reach out for orders. But we get all of our orders from a medical director.
Okay. So earlier you mentioned something that like the medication at the end of life care, what is that? And what is that misconception about that specific medication?
Yeah. So the medications that we give typically for patients who maybe don't have any allergies, to say morphine or anything like that, we want to give them morphine and Ativan.
Okay.
So morphine is for not only for pain, but it's also for shortness of breath.
Okay.
So
in those final moments.
And so we give a liquid concentrate. Okay. So that's different from taking a pill.
Right.
Because if you're going to take a pill, right, it's going to have to take not only 20, 30 minutes to start working, but it's excreted differently out your body. And then the half-life on those medications are different than a liquid. Okay. So if you have, say what we offer, which is the liquid morphine, we explain to the patients and the families that, they're gonna put it in their mouth because it's absorbed into their mucous membranes. And so it goes straight into the bloodstream. So it can take 5 or 10 minutes for it to start working. But we can give it as often as we can because it's a short half-life and it's excreted differently than something that's by mouth. But it can scare families. They think, well, gosh, I can give this morphine every hour. But once they're educated and they're explained that, wait a minute, like this is why, because the effect goes away after so long. And so that's why they can go ahead and have more. And that goes back to the terminal pain and anxiety that patients experience. And it really only takes one time for a nurse to witness terminal pain and anxiety and it not be medicated. And once they see that, they're able to testify and educate families that if we don't give this medication, this is what can happen. And what you get is it can be, a combative patient or somebody who is having extreme amount of falls. Somebody who's agitated to the point where they feel like they, say they've been in bed. A textbook sign is, I've got to get up and go to the bathroom. And so say you sit them, you help them to the bathroom and they don't do anything. So you take them back to bed. I've got to get up and go to the bathroom. And then you do that again, and it's just over and over. So if that isn't medicated, that patient is going to continue to act that way because they don't know what's going on inside their body.
And it's just like their anxiety trying to cope and like do something.
Because again, that when it gets to a certain point, that's where things start to shut down inside.
Yeah. I can only imagine because it's not like your body's just like, okay, we're done. Everything shuts off at once. It's multiple organs at a time. So, and then when one shuts down, the others don't work the same in tandem. So it's like,
well, and then you have organs that start to compensate,
right?
And so
that's got to be painful.
It is. Yeah, it is. And so that's where you explain, okay, we're gonna watch for, high heart rate and low blood pressure. That's just a sign that your heart is just working over to try to keep these organs perfused and alive until eventually, and so again, that's where it's so important that a hospice team can educate and explain to the family, like, this is what's going on, but we're going to help you. And, if you have patients that it happens that they ask you, hey, am I dying? And, we always say, if they ask you that, more than likely they already know they are. And they just want to hear it from you. And so we're always honest with them. We're not ever going to say, no, you're not, But at the end of the day, we all are, but we're gonna be there for that patient and that family. And so we're going to make sure and hopefully that, they're comfortable and again, they can fall asleep. So, yeah.
Oh my gosh.
If people want to know more about our hospice, we have a Facebook page. They can also go to alphaomegahospice.com. There's also some good YouTube videos out there. On end of life and like signs to look for and like things that can happen in the last year, things that can happen in the last months. So I encourage, if families, they say they're kind of there, but they're not there yet, that they can always reach out to us just for education. I mean, we come out and we educate. We don't always bring consent books to bring a patient on service. I mean, our goal is to advocate for the patient, to know that they, number one, have a choice,
Mhm.
and that number two, that hey, we're going to be there to support them,
Mm-hmm.
because they think it's just like, okay, well, we've got a nurse, but they don't know about the whole team,
Mm-hmm.
Right.
and what makes a great hospice
Mm-hmm.
instead of a good hospice is the communication,
Yeah.
and the compassion that the team has.
Yeah.
And so Misty and myself, we collaborate really well when we're hiring.
Mm-hmm.
It's not, I had a nurse come in the other day and say, hey, I appreciate that y'all don't just put in a warm body,
Mm-hmm.
Yeah.
because if somebody is struggling, or say they're busy with their caseload or whatnot, like I was saying, we'll go
Mhm.
out there and help. We're not just
Mhm.
going to hire somebody to
Yeah.
fill a
Right.
spot. Like
Mhm.
we want to make sure, hey, like
It's a good person. for this role.
absolutely,
Yeah.
absolutely, because we have all kinds of different personalities,
Mhm.
Mhm.
and it's like we all complement each other.
Good.
And again, it's true whenever they say you spend more time with your work family than you do your
Mhm.
family sometimes,
Mhm.
right?
Yeah.
And so that trust is also there amongst our
Mhm.
staff, because we couldn't work or mesh well together if we didn't
Yeah.
trust each other. And that's why I can honestly say that this is the best job that I've ever had.
That's
So
amazing.
yeah,
That's
Wow.
it really is.
Well, thank you and your team for
Yes.
what you do for
Yes.
patients and caring for them in those most special end of life
Thank you.
peaceful moments, because you're making such an impact in your field and what you do for patients and people.
Well,
Truly.
thank
And
y'all
I
so
love
much.
the compassion and passion that you bring
Mhm.
to what you do. Like, just from talking to you, I'm like, I love her. She's just like, you can tell she's just so compassionate.
Yeah.
So
Thank you.
thank you.
Cannot thank you all enough for allowing the opportunity to just be able to share about this amazing
Absolutely.
field of nursing. So
Absolutely. It is. It's very special, and
yes,
it's something that we haven't known hardly anything about
Sure.
either.
Mhm.
And so
Yeah.
we appreciate you being vulnerable and open and to coming
Absolutely.
to educate. So
yeah, you'll have my number, so you can
yes,
call me anytime.
Yes, absolutely. Well,
So
thank you.
I do
Lindsay.
thank y'all.
Thank you.
Mhm.
All right, and
Thank
tune in
you.
next time, guys.